Great, so we've talked about heart disease, and now we're going to shift and start talking about what's going on in the blood itself. So we're going to talk about changes in hematologic functions. And here's a picture. You can see all the red blood cells, the biconcave things that are red. You can see the white blood cells that look more gray in the picture to me, but they're white. What's interesting about this picture is if you know the difference between red and white blood cells, the red blood cells are a lot smaller than the white blood cells, and this picture makes them look the same size. And then those things that look like little starfish or something, those are supposed to be platelets, which are even smaller. So they're smaller than red blood cells. But here you can see all three components. It's just not a proportionately accurate picture. So when you think about blood, the term blood itself is talking about all of the stuff in that fluid that runs through your blood vessels. So it's thicker than water, it's heavier than water because it has a lot more components than water does. It's basically water and then add flour and some sugar and all that stuff to make a thicker paste. That's what blood is. So it's a lot more viscous or thicker and more dense. Its temperature should be right around 100 degrees Fahrenheit, where we usually try and keep it, because your core likes to stay right around that 100 degrees. Your pH of your blood depends on what part of the vessel it's in, so 7.35 to 7.45, 7.4 being the average. Of course, if it's in an area that has more carbon dioxide, it's going to be slightly more acidic. So which number is more acidic? 7.35. I know it still technically falls into the base side of 7.0, but that's actually the more acidic side of blood. And then if it's in an area that has more carbon dioxide, which vessels are you going to see this in more? Systemic arteries or systemic veins? Systemic veins. So always keep those things in mind. We covered all that in electrolytes a long time ago, like week number 2. The average adult has about 4 to 6 liters, so about 5 to 5.5, usually closer to 5.5 in males, closer to 5 in women. When you look at the concentration of electrolytes and all that, you can go back to the electrolyte section and review it. You have to have certain portions of sodium, potassium, chloride, calcium, all of those different things. And of course, what's going to be the highest, sodium or potassium in the blood? Should be sodium unless you've had damage to cells, which raise the potassium. So these are a lot of concepts we already talked about. We're basically going back and briefly reviewing. I also talked about this 1 kilogram of blood is equal to about 1 liter of blood. So a weight relationship is pretty close. The average male, 70 kilogram male, is going to have about 5.5 liters. So I already talked about that. When you look at the blood itself, if you separate it out, you can separate it into the plasma, which is about 55%, and the formed element, which is the other 45%. And I put this chart in because it's such a handy chart to use as a reference. But you can actually see, going back through here, what proportions each of these are and reasons they're there. Like white blood cells, why are they there? They're there to fight infection. What do you primarily see neutrophils come out for, eosinophils coming out for, basophils coming out for? Things we've talked about before, like in the infection section. We talked about a lot of these things before. We're just going to go back and highlight some of the problems and really focus on things like anemia and polycythemia. So breaking it down, the 55% plasma is mostly water with a lot of proteins in there that help retain the water. Keys you have to remember. It carries your nutrients, your hormones. So you're going to find things like cholesterol-based hormones, so steroids, estrogen, progesterone, testosterone, all of those flowing through. You're going to find, well, I already talked about albumin, but most of the electrolytes floating in here. This is the liquidy, watery part of the blood, so if you spin it down like this, it's that straw-colored stuff that floats to the top. You have your dissolved gases, so it's going to have like carbon dioxide and a very little bit of oxygen actually free floating. So mostly the oxygen will bind to what? Hemoglobin in the red blood cells, but you do get a little bit that free mixes with the plasma. And then carbon dioxide, it can free mix with the plasma a little bit more regularly than oxygen, but it's primarily carried by bicarbonate or as bicarbonate. And we'll kind of go over these just a little bit. But the formed elements are the whole pieces of things, like a whole cell or a whole section of a cell. Like for instance, red blood cells and white blood cells. They're whole cells. They're this formed element. The thrombocytes are technically not an entire cell to their self. They came from those megakaryocytes, but they're still a big chunk of a cell, so we call them part of the formed elements, where the proteins are up in the plasma and free floating. The process of making blood cells, and I'm not saying red, I'm not saying white, I'm saying blood cells, is called hematopoiesis. So that, by the way, where does it come from? Where do red blood cells get made? Where do white blood cells get made? They're both made in the same place, right? They come from this pluripotent stem cell. So a hematocytoplast or a hemocytoblast is a stem cell that can become any of the heme cells, red blood cells or white blood cells. When they're triggered by specific chemicals like erythropoietin, Erythropoietin, you know, made by the kidney, comes over here to the stem cell and tells it you need to become a what? A red blood cell. What about leukopoietin? What would this say? You need to become a white blood cell, right? So it tells the cell what to become, whatever the chemical is, tells the cell what to become, and then it starts differentiating into that pathway. So you can see that erythropoietin will turn into a pro-erythroblast. So it's a premature erythroblast. And then to erythroblast, a normoblast, a reticulocyte, which is just an immature erythrocyte. And a reticulocyte still has fragments of a nucleus in it. What do you know about erythrocytes? They don't have a nucleus. How many organelles do they have? None. They don't have organelles. They're just basically a big bag of hemoglobin with some enzymes in there to convert oxygen and CO2 into other things and to make a little bit of energy, but they can't use the oxygen. So what process do they use? Glycolysis, right? So they have some glycolytic enzymes, but that's it. That's all an erythrocyte is. So let's go ahead and talk a little bit about erythrocytes and which are red blood cells, right? So you know the primary purpose is to carry gases, right? Oxygen, CO2. Unfortunately, carbon monoxide it can carry too, but it's the most abundant cell in the blood. About 45% of all of your cells or all of your blood is actually red blood cells. It's that big lump down the bottom. When you spin out blood, the heavy stuff goes to the bottom. Why is an erythrocyte so heavy compared to all the other stuff in the blood? Because it's filled with hemoglobin. What is it in the hemoglobin that's so heavy? The iron, right? So you've got these big balls of hemoglobin with iron inside of them. And that's how you remember that they're heavy and they settle to the bottom. Because when you spin them really hard, the heaviest parts go to the bottom of the tube. The shape of these is really important. They're biconcave. They're almost like a contact lens with double sides to it. So you can squish it, they squeeze, so they can slide through blood vessels. If they can't squeeze down and compress, they can't fit through. So an old, worn-out red blood cell can't squeeze and goes to the liver or the spleen. They detect that inability to change and they destroy it. That's a sign that it's an old, worn-out red blood cell. Another purpose for that shape is actually because you increase the surface area. By having a biconcave surface, you have a bigger surface area, which increases the rate of diffusion. So you can diffuse things like oxygen and CO2 a lot faster. And I've already mentioned this, that red blood cells are just big sacks of hemoglobin. You've got about 250 million hemoglobin molecules in one red blood cell. Each hemoglobin molecule can actually carry 4 oxygens. So you can see there's a heme, there's a heme, there's a heme, and there's a heme. That's the iron that binds to oxygen. And we've talked about this before. When you oxygenate iron, it rusts. It turns this reddish orange or orange color, right? Which gives it that reddish color. When you deoxygenate it, it turns more of a burgundy blue color, which represents that bluish color to deoxygenated blood. Right? So that heme is binding to the oxygen. So one red blood cell has 250 million hemoglobin, which has 1 billion heme altogether, which means you can carry 1 billion oxygen molecules in one red blood cell. That's a lot of oxygen. Okay, and then the heme you're familiar with, it's 4 proteins. You have the alpha chains and the beta chains, and they stick together with the heme in the middle. If you misshape this part of the hemoglobin, it doesn't carry oxygen. If you are lacking the iron, it doesn't carry oxygen. If you can't give this whole red blood cell that good flexible shape, it can't carry nutrients. So if there's any problem with any of this cell, it doesn't work, and it, well, hopefully it's going to be killed or destroyed, and then you replace it with a new one. So look at the red blood cell life cycle. They stay alive for about 120 days, right? So you're constantly making these down. You break about 174 million every minute, which means you make about 174 million every minute, constantly being turned over. You know that it's stimulated by a chemical that comes from the kidney, erythropoietin, which goes to the bone marrow, red bone marrow, and stimulates the stem cells to become erythrocytes, right? They stay in circulation for about 120 days where they get old, worn out. They have no DNA. They can't repair. They go through the spleen and the liver, and the spleen and the liver will break it apart and destroy it. It turns it into heme groups and globulin groups. These are proteins, and these are the iron. The iron can be recycled. It can also be turned into bilirubin, which goes to the liver and gets processed and turned into bile or ejected into the feces, which gives it kind of a yellowy-brown color. The amino acids can be broken down, recycled, and used other places. You know, your body uses lots of amino acids, right? So there's your basic cycle. You have to have certain nutrients that you get from the GI tract to be able to make those red blood cells. You have to bring in iron. You have to bring in B12, folic acid. If you don't have any of these, you can't make a successful red blood cell. And of course, if the red blood cell is not perfect, it doesn't work. So we're going to talk about some of those problems now. Okay, one of the problems that can happen is you can actually have an increased sedimentation rate. And this is something you test for in a lab, where you can take the blood, it's uncoagulated blood, but you look at it for an hour, and you look at these little red blood cells. And if they start sticking together, or what they refer to as the rouleau effect, or rouleau formation. I always think of that word and I look at Rolo, because it looks like a stack of Rolos, you know, that candy you used to buy that was in the gold wrapper, where they're all perfectly stacked. Normal erythrocytes don't like to stick together, unless they're triggered to. But in the presence of an inflammatory response, if you have inflammation anywhere in your body that's getting in, affecting the blood, these red blood cells will start sticking like this, which is a good thing at the site of infection, because then it sticks together and causes that clot, helps clotting. But you don't want these free floating through the blood. So here you can see they're kind of like Rolos sticking together, where you have a lot of these free floating ones. These are kind of organizing themselves. They're the same thing here. Right? So this is actually a way to identify inflammation. Oops, I have a typo there. So here's the progression. What happens is inflammation enters the blood, alters the blood proteins, causes them to start sticking together. They fall out of the fluid faster, which means they clump a lot easier, and they stick usually to wherever the blood's leaking, like a broken blood vessel, a busted capillary. Wherever the blood's leaking, these heavy groups of red blood cells will start going in there and plugging it up. So it creates a clog, which is a good thing for that clot, but a bad thing if it's all through your system. So when we do this test, we don't do it to identify any one particular disease. We're just doing it to identify if there's inflammation in your body. So here's another thing. I kind of slipped and told you the answer, part of the answer is, what is a reticulocyte, and what significance does a reticulocyte have on determining dysfunctions in the body? So when you take a blood sample, when you go into a doctor's office, first couple things they usually want is they want you to pee in a cup and they want to take blood, right? Because it's good indicators for what's going on in the internal environment. So when they take a blood sample, if they see high reticulocytes, they go, uh-oh, right? Why? That's the question. So what is that reticulocyte? You can actually look at the picture and kind of figure that out. And then what's it indicating? What do they want to know? If you have high reticulocytes, so normally about less than 1% of your blood, of your red blood cells, are reticulocytes. What happens when that spikes up to like 30% or 25%? What's going on in your body? All right, let's go into the anemias. So anemia in general is just the inability of the blood to carry sufficient oxygen. It's not specifically saying you have too few red blood cells. What it's telling you is that you can't carry enough oxygen. All right, here are the different types of anemia you can see listed in the chart, all spread across here. And we're going to talk about some of these, like iron deficiency anemia, the ability to make the red blood cells, hemolytic, which means you're destroying the red blood cells too fast, faster than you can make it, acute bleeding, so a hemorrhage, actual damage to the bone marrow so that you can't make it, and then inflammatory and chronic disease issues. So anemias are a low number of red blood cells or their lack of hemoglobin. Right? So like I said before, it doesn't mean you necessarily have to have low red blood cells. You can have plenty of red blood cells, but if there's something wrong with the heme or the hemoglobin, you still can't carry oxygen, so you have a deficiency. Or you can have normal red blood cells, but you just don't have enough of them. All right, so here are the clinical manifestations, and you can see kind of the flow chart. Right? So affecting the brain, affecting the heart, the lungs, the skeletal muscle. All these things depend on high levels of oxygen or movement of oxygen. So the brain, you're going to start getting tired, sleepy, you get easily mentally fatigued, right? You can pass out and go to sleep. When you get carbon monoxide poisoning, what's happening is the carbon monoxide binds to the heme and you can't carry oxygen. So these people have normal levels of carbon dioxide, but they don't have enough oxygen. As the lack of oxygen starts affecting the brain, they get tired, they get sleepy, they fall asleep, and then they die. So what's that tell you? Is your body more sensitive to oxygen levels, or more sensitive to detecting oxygen levels, or more sensitive to detecting carbon dioxide levels? Well, it's obviously not the oxygen levels, because you can just get tired and sleepy when you have carbon monoxide poisoning. But if you get in a room where there's too much carbon dioxide and it's filling up in your blood, you get panicky, you get anxious, you start freaking out. So watch for the clinical manifestations of oxygen changes. It's usually not the person freaks out, it's that they start having an increased heart rate. Why would their heart rate go up? Well, their heart rate goes up because they're not getting enough perfusion or enough oxygen to the tissues. So the heart rate goes up to try and carry more oxygen faster, right? But if it's carbon monoxide, it's not going to help them that much, right? They get dyspnea. They have a struggle breathing. Why do they feel like they can't catch their breath? because they're not capturing enough oxygen. So they can breathe deep. They're like, oh man, sometimes I just can't feel like I catch my breath. Okay, with anemia, because they feel like they're not getting enough oxygen. Okay? They can have angina. The heart's not getting enough oxygen, so it starts having the mitochondria release free radicals, and it causes that pain, the angina. They may look pale, because if they're not getting enough oxygen, they'll start vasoconstricting the peripheral tissues. Well, if they vasoconstrict, they're not carrying oxygen to the peripheral tissues. They're trying to keep it inside. So that can be another problem. If you have enough red blood cells and enough hemoglobin, but you're not getting enough oxygen, sometimes what will happen is you start turning blue, because that deoxygenated blood starts causing that change. So cyanosis can be a problem usually of not getting oxygen into the body, right? Not that you can't carry the oxygen. Because remember, anemia is not able to carry oxygen. So you don't have enough hemoglobin. Hemoglobin is what gives that blue color if you're turning cyanotic. Right? And then fatigue, you feel tired, you feel weak, you start to exercise, you just feel like you can't do it. You walk up a flight of steps, you're just tired by the time you get up to the top. And it's funny because some of these symptoms actually overlap with heart disorders. So, and then syncope and fainting. So you can see lots of the problems that are going on here. And the primary issue revolves around tissue hypoxia. You're not getting oxygen adequately to the tissue. Remember, hypoxemia is low oxygen in the blood. Hypoxic tissue is, or hypoxia is low oxygen in the tissues. And we're going to talk about some of these things. So you can get blood loss causing anemia, hemorrhage, right? Maybe you don't make enough red blood cells, or you don't make the right red blood cells. That causes anemia because you can't carry the oxygen. Maybe it's because you're making enough red blood cells, but they're being destroyed too fast. And then you see in that situation, that bilirubin floating through your blood is going to cause things like jaundice. Right? You'll see an increase in erythropoietin. You'll see more of those reticulocytes. And the reticulocytes are a sign kind of that you're breaking down red blood cells too fast. So if you have an internal hemorrhage, an internal bleed, you know, it doesn't look like you're bleeding anywhere, but you're actually bleeding to death. So you feel tired. You can't catch your breath. You just feel weak all the time. Maybe you're pale a lot. You go get checked out, they take a sample of your blood, they see high reticulocytes, and they go, uh-oh. And they kind of get freaked out a little bit. And I think I just answered your homework question. Nuts. Okay. So another problem that can happen because of anemia, and they call it cardiorenal anemia syndrome. Sometimes they refer to it as cardiorenal syndrome, and that's when the heart or the kidneys are failing, right? Because the heart and the kidneys, when either of them are failing, they usually affect the other one to fail. So they call it cardiorenal. When you throw in anemia, then they call it cardiorenal anemia syndrome. And you can see the loop. It could all start because of anemia. And here's the pathogenesis. So let's say you get any kind of anemia that we're about to go over. Right? The anemia causes hypoxic tissue. Well, when your tissue is hypoxic, you get peripheral vasodilation to try and bring more blood to that tissue. So nitric oxide is released to open up those blood vessels. Right? But the problem is that now you have decreased resistance, which means your blood pressure drops. As your blood pressure drops, then the sympathetic nervous system is going to freak out and say, whoa, 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 we're not getting enough oxygen to the brain. It turns up your release of noradrenaline and adrenaline, right? So norepinephrine and epinephrine. So you start having a faster heart rate, tachycardia. But now that adrenaline is causing the peripheral blood vessels to constrict. So you squeeze down those blood vessels, and now you're not getting adequate flow to the kidneys. So now look at anemia to renal. Now the kidneys decrease their GFR. They're not outputting urine enough. They're decreasing their renal blood flow, which is killing the kidneys. It's causing them to start shutting down. Well, the kidneys don't like that. So what they do is they release renin-angiotensin-aldosterone pathway, right? So they release renin. And then it causes you to start vasoconstricting more. It causes you to start retaining more water, which raises your blood pressure. Your hypothalamus starts releasing ADH, which raises your blood pressure by retaining water and vasoconstricting. So now you've got kind of this loop. This all started because of vasoconstriction, because of low blood pressure. Well, you're fixing the low blood pressure and you're raising it back up, but you're also increasing the vasoconstriction of the kidneys. So that's causing more damage to the kidney. Think about the blood pressure. Your blood pressure is starting to spike now, which is causing more stress on the heart. It's causing the heart to have to push harder, which causes hypertrophy, right? And if the blood is not getting to the myocardium enough, you start having damage to the myocardium. You start having necrosis. You start replacing with scar tissue, which is going to decrease your pumping, which means that you're going to go back to causing more problems to the kidney. It's a very dangerous loop that you fall in. But you can see when you get renal failure, it typically leads to anemia and cardiomyopathy, heart failure. When you get heart failure, it has a tendency to lead to anemia and renal failure. When you get anemia, it has a tendency to lead to heart failure and renal failure. It's a negative loop, not a negative feedback loop. It's just a deteriorative, dangerous loop, right? All right, so how do we classify these anemias? How do we talk about them? In general, you can say you have a low production or high destruction. I mean, those are the general, very broad groups. So production, maybe think of it like a factory. If you're not producing enough of the red blood cells in this factory, maybe it's because you're missing the demand. Maybe there are no orders coming in. Think about erythropoietin. If there's no erythropoietin coming into the factory, there's no order or demand for it. So your body just doesn't make it. That would be because of kidney failure usually, right? Maybe there's a flaw in the factory. Maybe the factory's not working efficiently to make it. So maybe the DNA, the code isn't right. Maybe the products to read or make the DNA isn't right. Well, then the factory fails. Maybe it's defective machinery. Maybe an enzyme in the process isn't working. So now you have this process where you have the right equipment, you have the right directions, but the machinery is defective. Right? Maybe you're missing the raw materials. What, of course, is going to be a raw material for hemoglobin? There's two main raw materials, right? You need something to make proteins. You need something called heme, right? Iron to make the heme. So what if you're missing those? If you look through this production list, these all go into that. Maybe there's something wrong with the factory, abnormal bone marrow. Maybe you're missing some of the factors, the enzymes. Folic acid or folate and vitamin B12 are important for that enzymatic process. Maybe your demand has changed, right? The stimulation of the factory. So erythropoietin isn't being released. Any of those things can actually go wrong. And then we'll talk about these last ones, ineffective erythropoiesis, so thalassemia and sideroblastic anemia. All right, look at the other side. Maybe all these work fine. You're making plenty of red blood cells, but you're destroying them too quick, right? So hemolytic anemia means that you're making them, but they're getting broken down. Maybe they're misshapen. Maybe they're not working appropriately, but like that, and then the spleen and the liver destroy them. Maybe you're losing them. Maybe you're bleeding out. And if you're bleeding out, you just can't keep up with that demand. So you make about 174 million red blood cells every minute, but the problem is that if you're losing 300 million every minute, you're not keeping up, right? That causes anemia. So you can classify it that way. So is it possible to have normal hematocrit, which is a normal number of red blood cells, and still have anemia? Yeah. Go back to that production list and look. Maybe the factory is defective, which is aplastic anemia. You're just not able to make enough or the appropriate red blood cells. Maybe you don't have the raw materials, like iron. Maybe things like B12, you don't have the machinery working appropriately, right? So you make enough red blood cells, they just don't work appropriately. So we can also classify anemias by the size and the hemoglobin. So the size of the cell, when you see something acidic, like macrocytic, you know it's a big cell. When you see microcytic, it's a small cell. If you see normocytic, it's a normal cell. So the size of the cells can make a difference. The color is another one. What gives red blood cells their color? Almost slipped on that one, right? It's the hemoglobin, it's the iron. So it could be the hemoglobin content. Maybe you don't have enough hemoglobin, right? So that would be hypochromic because it's not red enough. Or there's normochromic, which means that you have enough hemoglobin and it looks normal color. So you can have different mixes here. You can have a normocytic, a normal-sized red blood cell that's also hypochromic, which means it doesn't have enough color to it, which means that you're not providing it with enough hemoglobin, right? So here are some of the problems that happen with microcytic. So here you see some of the problems that happen with normocytic. Here you see some of the problems that are happening with macrocytic, and we're going to cover these. But it's a nice review or preview chart, I guess, here. Okay, so let's talk about the macrocytic or megaloblastic anemias. Macro and mega, they sound big, right? So these cells are huge compared to normal. And you can see this picture over here. There's a normal red blood cell, normal white blood cell. Here you can see they're way bigger than normal, right? So here are some of the problems. And I'm going to talk about white blood cells just briefly here, but we'll go over white blood cells again later. When you see macrocytic white blood cells, usually what you're seeing is they have more lobes than normal. Like in this situation, you have this megaloblastic white blood cell, this big white blood cell. Instead of having 3 to 4 lobes like a normal neutrophil, this one has like 5 or 6 lobes. Actually, this one has 7, right? 1, 2, 3, 4, 5, 6, 7 of them. When you look at the red blood cells, here you can see normal red blood cells. Look at this giant monster, or that giant monster, or that one, right? They're gigantic. So in this situation, you usually have enough hemoglobin, but the problem is that the cells are gigantic. So would you call that hypochromic or normochromic? It's normochromic. It's the normal color. Typically, the problems with these are going to be folate and B12 deficiencies, and we're going to actually talk about them here. What would be a big problem with having too big of red blood cells? Well, if blood vessels, capillaries, are only about 8 nanometers tall, micrometers tall, and a red blood cell is 7 micrometers tall, what if you have this gigantic, like 10 micrometer red blood cell? It's not going to squeeze through the capillaries very well. So you could risk things like clumping and clotting. Right, so some of the symptoms, just like normal anemias, weakness, short of breath, tachycardia, you're trying to push the blood faster to try and pick it up. A lot of times with these, you see GI sensitivity, nausea, and pain. And here's why. Any cells that are rapidly reproducing depend on folic acid and B12. This type of anemia, what we said, we're going to revolve around folic acid and B12. So any type of cells that are rapidly replicating, like the GI tract that turns over about every 7 to 10 days. Your red blood cells are turning over every second, right? Your skin is constantly turning over. If you have problems with folate and vitamin B12, usually with this type of anemia, you'll see GI sensitivity, nausea, and pain too. So it's just an interesting thing. The same thing with the skin. You can see hyperpigmentic sections. So some areas that are overactive where other areas are inactive. So a lot of times you'll see it like on the tongue. So they can get glossitis or inflammation of the tongue. They can also get these red, like hyperpigmented patches. You can see it on the skin, hyperpigmented areas. See it on the toes. But discolorations. It's just one of those characteristics that a lot of times comes along with this type of anemia. Okay.